Good afternoon, and welcome to another edition of Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the National Minority Organ, Tissue, and Transplant Education Program, and the Pennsylvania Avenue Baptist Church. My name is Jennifer Arrigo with the GW Ron and Joy Paul Kidney Center, filling in for Dr. Reverend Kendra Curry with the Pennsylvania Avenue Baptist Church. Today, our presentation will be on liver disease 101. An Introduction to Liver Disease and Liver Transplantation by Dr. Zahid Vahora and Dr. Amir Abu Talib, both hepatologists with GW's Liver and Pancreas Institute, which is part of the GW Transplant Institute. We are so excited to have these two physicians here with us today. Doctors Vahora and Abu Talib are joined by our esteemed panelist, Dr. Clive Callender, who is a professor of surgery at Howard University's College of Medicine. In 1991, Dr. Callender conceptualized and founded MOTEP for the purpose of increasing minority donation rates nationally. Without further delay, I would like to turn things over to Dr. Vahora. Dr. Vahora, please take it away.
Welcome, everyone. Thank you so much for coming on for this talk. I wanted to kind of create a kind of a liver disease 101, kind of an introduction to liver disease here. So we will kind of go forward from here. So some basic facts about the liver. It is the second largest organ in the body. Weighs about 3 pounds. It's that brown thing right there up in the at the top part of the body there. Essentially the stomach and intestines, they basically digest what we eat or drink and then turns it into raw materials that then the liver uses and as the blood filters through the liver cells break down these materials, purify them, and use the stuff that we need and get rid of the harmful materials thereon. So the liver does many jobs, many jobs, and as you can see from this thing, not all heroes wear capes, and yes, the liver is the hero of the body. I'm a little biased, being a liver specialist myself, but the liver makes many proteins, some other substances that kind of help with blood clotting. It helps get rid of toxins such as alcohol. We'll touch more on alcohol as well. It does produce bile that we need to help digest our food. And of course, it uses, helps store certain vitamins and sugars for us as well. And, basically the liver is made up of multiple cells that we call hepatocytes, and they work together around the clock to kind of make sure we have a functioning body. So kind of another kind of graphic here, kind of, so the liver detoxifies, it filters, it's a factory, it helps store things, and of course, it has bile to make food. And of course, another function of the liver is really temperature control, to help maintain the body's temperature as well in many ways. So as you see Scooby-Doo here kind of complaining about his liver, the word hepatitis, and I always like to kind of mention this when I talk about the liver, hepatitis is a general term. In many ways, hepatitis is a general term like pie. When someone says, hey, they had pie, we often want to know what flavor of pie. In just the same way, there's many flavors of hepatitis, because the word hepatitis just means inflammation of the liver. And of the many flavors of hepatitis, there's certain viruses, alcohol can do it, fat can do it, autoimmune diseases, and many other things can do it as well. Now, with the liver, the longer that process of inflammation from the many different types of hepatitis are there, it causes damage or type of scarring to the liver called fibrosis. And that fibrosis can kind of progress, and we'll kind of go over that a little bit here. But generally, the liver doesn't cause pain. In rare cases, there can be some acute inflammation from the liver when it causes the liver to swell, but usually hepatitis generally doesn't cause pain. Now, when we talk about fibrosis, that scarring, when there's a factor that kind of insults the liver, we know that the amount of scarring, we stage it based off essentially a 5-point scale, 0 being the first point, basically F being fibrosis, so F0 to F4. F4 cirrhosis is stage 4. F4 liver disease is the same thing as stage 4 liver disease, also known as cirrhosis, also known as end-stage liver disease. But as you can see here, this is the progression that the liver goes through to get to cirrhosis of the liver. So we'll kind of go over the different factors, kind of generally to what causes, liver fibrosis, liver damage, and then we'll go over a little bit of cirrhosis too. So number one, I really wanted to talk about was alcohol. So, alcoholic liver disease attributed to heavy alcohol use, and it is a potentially reversible cause of liver disease. Once you remove the alcohol, the liver. Um, and if you're in a relatively early stage of liver disease, before stage 4, the liver can reverse itself, and get better. However, the key is really abstinence. While abstinence is key, the important part is really kind of treating the underlying alcohol use disorder. And I really kind of want to talk about alcohol use disorder. This is a disease just like any other. We don't really call it alcoholism or anything like that because we know that this is a disease that needs treatment just like any other. While people need to stop drinking, it's important to treat the cause that pushed them to drink so that they don't go back to drinking and cause more liver disease. The next slide. So really, I wanted to talk about, kind of a standard drink. In the U.S., one standard drink is about 14 grams of alcohol, and I borrowed this slide from a colleague of mine. So that really means about roughly a 12-ounce can of beer, 8 to 9 ounces of malt liquor, 5-ounce glass of table wine, or one and a half ounce shot of 80 proof spirits. And so really what happens is that, that's really the standard drink. And for men, it's about 2 of these standard drinks is really kind of the daily limit. For women, 1 of these. So it really begs to see how much actually in our society we are drinking beyond the standard drink. And once we go beyond the standard drinks, we tend to put ourselves at risk for alcoholic liver disease. So kind of going forward, while we have alcoholic fatty liver disease or alcoholic liver disease, we also have non-alcoholic fatty liver disease, or also known as non-alcoholic steatohepatitis. These are shortened as NAFLD or NASH in these patients. So we know that, as we may gain weight or develop what's called metabolic syndrome, diabetes, high blood pressure, high cholesterol, cardiovascular disease. The body stores our extra nutrients and thus fats within the liver. And as time goes on and we build up the extra stores of those fats, more and more fat gets into the liver, and that causes the fat to form. And that's what the non-alcoholic fatty liver disease is. But this is a spectrum. As that more fat develops in the liver, the fat eventually ends up causing inflammation. And that's what we call NASH, that's steatohepatitis. And as that NASH is persistent for years and years and years, that eventually causes cirrhosis. And once you have cirrhosis, it can lead to hepatocellular carcinoma or liver cancer. It's important to know that just like most liver diseases, if we can halt the fat deposition in the liver and the inflammation, this disease can be reversible back to a healthy liver. So really, what do we do for this? What are the mainstays in working? How do we treat NASH? So we know that, of the society guidelines of the American Society of American Association of Study of Liver Disease, the European Study, and the Asian Pacific liver societies, the mainstay is really lifestyle modification, dietary changes, weight loss, and exercise. And so we know that when patients reduce their calorie deficit by 500 to 1,000, and there are studies that show that this actually improves it. And with the goal weight loss, and a lot of times patients tell me, doc, I get it. I've been told I need to lose weight, but how much weight do I really need to lose? And the guidelines really say, about 7 to 10% of your body weight. And if you think about it, someone who is 200 pounds, and if that is, overweight or obese for them, we're really saying about 20 pounds. And they may want to lose more, and patients often say they want to lose more, but for their liver to get happy and kind of work against this fatty liver, it is really just about 7 to 10% of the body weight, or 20 pounds if you're about 200 pounds or so. Um, so we know that exercise alone doesn't really work on this, but we have to kind of work. Sorry, exercise alone may prevent this. So it is. We talk about aerobic exercise and resistance training. Really, kind of patients can tailor this to their preferences and what they kind of like to do. But exercise is a key part of this as well. And sometimes we have patients who have tried diet and exercise for weight loss, and sometimes doesn't work. Sometimes we have patients who have other limitations, such as really bad osteoarthritis, where they're not able to get that exercise in that they want to do. And some people just have struggled with their weight, and we understand that. In those patients, we do have the option of bariatric surgery, referring to our bariatric surgery colleagues to kind of discuss, various weight loss surgeries, because we know that this actually does help, and it can help with these patients. Now, the issue with bariatric surgery, it is a little limited in patients when patients have cirrhosis and complications of cirrhosis. So we'll move on to viral hepatitis as another cause of liver disease here. Next slide, please. So this is basically a viral infection of liver cells, and thus again causing inflammation, cell death, and then inflammation, scarring, and essentially fibrosis. So hepatitis C, I do believe it still is. It surely won't be the leading cause of indication of liver transplantation in the United States, but historically it has been. This is a disease that travels blood to blood from patients. So we're talking about, patients at risk are people who have had intravenous drug users, intranasal drug users as well, unprofessional tattoos. Patients within our prison population have a higher risk of this as well. So there are about 17,000 new cases of hepatitis C each year. There was an initial dip in that, but with the opioid epidemic kind of increasing, we've seen an increase in this as well. And as many as 75% of patients with chronic hepatitis C have been unaware of this. And we're seeing younger and younger patients coming in with hepatitis C because of the opioid epidemic. So our United States Preventive Task Force suggested that and put a guideline out that all adults should be screened for hepatitis C. The reason being is that we actually have a cure for hepatitis C, not just a treatment, but a cure. And, early detection is really key for these patients. So not just the people with the risk factors, with the history of drug use or unprofessional tattoos, but every adult should be screened for hepatitis C, because we can cure it with a very simple pill-based regimen to treat them. And that's something we do here in our office as well. Now, the other viral hepatitis I wanted to touch base on was hepatitis B. This is actually one of the leading causes of liver cancer, hepatocellular carcinoma, which is a primary liver cancer in the world. And we know that it can cause cancer prior to causing cirrhosis. This is treatable, but not curable. And there's a vaccine along with hepatitis A. So we know it can be treatable, although not curable, but can definitely be prevented. So we definitely recommend all adults and children should be vaccinated against hepatitis B. Next slide, please. Another cause of liver disease is autoimmune disease. This is essentially when the patient's own immune system, for no fault of their own, attacks various parts of their liver. This is not contagious. There's no fault for this. Most people don't feel any symptoms at all. They feel perfectly healthy. However, some may have some vague aches and pain, decreased appetite, fatigue, and sometimes they even have jaundice, that yellowing of the skin and eyes. There are essentially three types of autoimmune diseases, two which affect the the bile ducts, the pipes within the liver that produce and drain bile out of the liver. And then, of course, there's the one that really affects the specific liver cells in these patients. So for this, we have, there's various treatments for this that we can kind of entertain with patients. For the most part, for these types of diseases, it's important to diagnose it. For two of them, they require liver biopsy. For another one, requires an MRI to diagnose it. So other liver diseases, just to kind of touch on for completion's sake, there's hemochromatosis, which is an iron overload. It's a kind of it can be a genetic disease. Alpha-1 antitrypsin, which is a deficiency of this, can cause liver disease as well. Wilson's disease, which deals with copper metabolism within the liver. Of course, amyloidosis. There's certain liver sarcoidosis as well, and of course, polycystic liver disease also. So I kind of want to go more towards cirrhosis and talk a little bit more about this. As we said, this is stage 4 liver disease, also known as end-stage liver disease. The diagnosis of cirrhosis, there's several: physical exam, blood work, imaging, and of course, a liver biopsy and fibroscan. On physical exam, oftentimes you find patients with, red palms, spider-like veins on the faces and body, fluid buildup in the belly, yellowing of the skin or eyes. And as you can see, a healthy liver here is nice and smooth, but a cirrhotic liver is nodular and scarred there. So here's some other signs. You see that yellowing of the whites of the eyes, yellowing of the skin in the upper right picture. You see that palmar erythema, that redness of the palms, and then these spider type veins that can be there. These are usually associated with cirrhosis. They're not always associated with cirrhosis, but patients who do have this can have cirrhosis. So just because you have these doesn't necessarily mean you have cirrhosis, but they are commonly associated with them. So coming on to cirrhosis here, as we said, this is what we call end-stage liver disease. There's essentially 4 major complications of liver cirrhosis, and I usually call these the 4 horsemen. These are the 4 horsemen in the sense that these are the main things that can cause the unfortunate demise of our liver patients. One is bleeding. These patients can have this bleeding, usually from esophageal varices, dilated veins in the esophagus that can form from the cirrhosis, and they can rupture in a hemorrhage. Of course, there's hepatic encephalopathy. One of the main jobs of the liver is to filter toxins out of our blood. When those toxins build up, they can but when they build up and the liver has cirrhosis, it cannot filter those toxins. Those toxins cause the patients to become confused, forgetful, and at the extreme end of the spectrum, end up in a coma. And of course, ascites, that's that picture. Picture there with that belly full of fluid there that occurs with cirrhosis. And of course, hepatocellular carcinoma, which is liver cancer. Next slide, please. So liver cancer, hepatocellular carcinoma is the main primary liver cancer in patients. The risk factors include cirrhosis of any cause and of course hepatitis B, as we mentioned. It is the fastest growing cancer death rate in the United States and has a pretty poor survival, about five-year survival of less than 5% if gone untreated. It is diagnosed with imaging, does not really needs a liver biopsy. That's because the liver cancer is supplied by arteries, and so we don't want to cause bleeding of the patient by putting a needle in there. So usually we need a CAT scan or an MRI, multi-phase CAT scan or an MRI to do that. Treatment is based off the type of cancer present, stage of the cancer, and other information, and it is an indication for liver transplantation. So as we said, usually it's liver cancer, just like most things with the liver, especially the liver inflammation, doesn't really cause symptoms alone, but left untreated, it can cause pain in the right upper quadrant of the abdomen here. We can travel to the shoulder. It can cause swelling or fluid buildup, like we saw with the ascites. It can cause yellowing of the skin if there is blockage. The tumor blocks drainage of the bile and can cause nausea, vomiting, poor appetite, and weight changes as well. Apologize. Ellis, I don't think I sent you my most recent slide deck. I apologize. I just realized that I was going halfway through the presentation. But I also wanted to kind of talk a little bit more about, liver transplantation. In terms of liver transplantation, we really, there's many indications for liver transplantation, many reasons. The reason mostly can be cirrhosis, liver cancer, and acute liver failure. We determine if a patient is a transplant candidate a couple of different ways. First, we look at what's called the MELD score, which is called the model of end-stage liver disease. This score essentially goes from a little over 40 being the highest, and those patients are the sickest, to about 6 being the lowest. And the score kind of correlates to the telling us how sick someone is at any given point by looking at specific blood work, usually the bilirubin, the INR, which is a clotting factor that the liver makes, the creatinine, which is a function of the kidneys, and the sodium. And the score correlates to a 90, what we say, 90-day mortality. It's basically the chances of a patient dying within 90 days. So if the score is 40 or above, it's about a 70% chance of dying. If it's in the 30s, it's a 50%, roughly a 50% chance of dying. In the 20s, about a 20% chance of dying, and then so on and so forth. It kind of goes lower the lower you go. Once that MELD score starts getting into the teens, and we start seeing patients and the MELD score starts going into the teens, that's usually when most liver transplant centers want to initiate what's called the transplant evaluation. The transplant evaluation is basically a combination of a medical evaluation and what we call a psychosocial evaluation. The purpose of this is to really see, is the patient sick enough to need a transplant, but not too sick to survive a transplant? So in the medical evaluation, we evaluate you make sure their heart is okay. We make sure there's no blockages in the arteries of the heart. Make sure their lungs are okay. Make sure that they don't have any other cancers outside of the body. Make sure that if they're up to date for a colonoscopy, if they're women, they've had a pap smear, mammogram, things like that. And the psychosocial evaluation is mostly to ensure that patients after a transplant need a lot of assistance. It's a major surgery. They'll need assistance with their medication, coming to and fro for clinic appointments. So the psychosocial evaluation is really making sure, hey, does this patient have the ability to have a care plan, a care support team to help them take care of this organ and take care of themselves after transplantation? Are there any barriers to them taking medication or anything like that? And then kind of working up from that side and making sure that using this as a tool to find any trouble that the patient may have, and then working to make sure they overcome that trouble so they can become a liver transplant candidate. So that's kind of the overall side of liver transplantation, which I believe a slide, apologies, kind of got left off from there. But we can kind of proceed with questions. I think we have some questions here. And Dr. Abu Talib, if you don't mind kind of helping me out with some of these questions here.
Sure, I can actually help too. First of all, great presentation, Dr. Vahora.
Thank you.
That was very comprehensive. I learned a great deal from it. Being on the kidney side, I was not that informed of the liver side, and really appreciated all that information. Dr. Callender, do you have any questions for Dr. Vahora directly? We have one from the audience, Deborah. Great question, and we're going to get to your question in a moment.
One question I'd like to ask is, you mentioned the term biopsy.
Yes.
What does that mean from a patient's perspective?
So great question. So a lot of times we can arrange for a patient to have a liver biopsy. Most of the times a patient with cirrhosis, we're able to diagnose their cirrhosis without needing to do an invasive test such as a liver biopsy. Their imaging can show a nodular shrunken liver. Their blood tests kind of show this concern for cirrhosis, as I said, and the physical exam can show it as well. However, sometimes there are reasons we might need to get a liver biopsy. Sometimes if the patient has elevated liver enzymes and we're not sure what the etiology is, we're concerned it might be an autoimmune liver disease or something else, we have to get a biopsy. Basically, a biopsy is using a needle, sedating the patient, using a needle to get a sample of the liver out so we can look at it with our pathologist, the doctor who looks at these biopsies, to determine two basic features that we're looking for when we get a biopsy. One is what the cause of the patient's inflammation, what the cause of the patient's liver disease is. The biopsy helps us with that because different liver diseases cause different patterns of inflammatory cells to kind of pick up in the liver and have different changes within the liver. That's one, the cause of the liver disease. And the second piece is it tells us what the stage of the liver disease. If you recall, there was that spectrum for stage 0, 1, 2, 3 to 4. The biopsy will tell us what stage the liver is within that spectrum there too. Now, in our clinic, we also have a very state-of-the-art technology known as the FibroScan. So basically, this can stage the liver in our clinic in real time without needing to cut anyone open. Basically, it's similar to an ultrasound. It pushes sound waves through the liver and can correlate, and that correlates to how much scarring or fibrosis there is in the liver. And we can, before patients even leave the office in moments, we could tell them what stage the liver is at.
That's very impressive.
Thank you very much. I wanted to ask you one more question before Jennifer turns it over to the rest of the audience, and that is there a way to avoid a biopsy, for example, by getting scans that can help you know how much scarring there is in the liver?
Yeah, absolutely. There are many technologies that we can use. I can kind of have pull Dr. Abu Talib in here, and other technologies that we can use in lieu of a liver biopsy to stage a liver. Dr. Abu Talib?
Yeah, there's a combination of different things that we can look at to assess whether somebody has advanced liver disease or not. Some of the simplest things that we can do is just look at the usual blood work that patients will get through their primary care doctor or through another specialist. And some of those patterns of blood values can clue us into whether the patient has liver disease. We can also use imaging to help us figure out whether a patient has liver disease, like an ultrasound, a CAT scan, or an MRI.
Yeah, and as I said, the FibroScan can tell us if can give us if they're stage 0, 1, 2, 3 to 4. There are certain MRIs that can do that too, so called MREs that can also kind of stage the liver disease in particular too. But as Dr. Abu Talib said, yeah, we have lots of different ways to kind of really tell if someone has cirrhosis or more advanced liver disease as well, without having to do a biopsy.
Wonderful. Thank you very much for the great dialogue. All right, so we are going to go to the audience now. Some great questions are coming in. So Deborah would like to know, if you have a fatty liver, will your cholesterol levels be high or could they be normal? If you have high cholesterol, is it possible you have a higher propensity to have a fatty liver?
Dr. Abu Talib, would you like to take this one here?
Sure, it's a great question, Deborah. There are certain patterns that we do notice in patients with fatty liver disease. More often than not, they tend to have diabetes. More often than not, they tend to have high blood pressure. And more often than not, their cholesterol numbers are abnormal, specifically a particular number called the triglycerides. This is part of the cholesterol panel. And if that is elevated, we tend to see that pattern in fatty liver disease. I think if you have high cholesterol in and of itself, that's not enough for your primary care doctor to go looking for a fatty liver. But certainly if you have diabetes, high blood pressure, and high cholesterol, it's something that should be on your primary care doctor's mind, and he should keep an eye out for it, or she.
Great. All right, so Ms. Robinson, would like to know how to prevent liver illness. Is there any particular dietary things do we need to do besides not drinking heavily?
Yes, absolutely. Drinking is kind of the low hanging fruit of not drinking heavily. But as we said, there are mostly the dietary causes of liver disease are mostly what we call non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. So really following a well-balanced diet, less fried food, fatty foods, and things like that. If you are diabetes, making sure you're following a diabetic diet, less carbohydrates, less simple sugars, and things like that as well. Especially a lot of folks who are pre-diabetes to prevent you from kind of going into diabetes as well. But I think working on a well balanced diet, lots of fruits and vegetables, a diet of good grains and things like that, and just eating smartly, which definitely can be hard sometimes, especially working. Sometimes you just grab something really quick here, grab something really quick there, grab something through a drive-through on the way home from work when you're having a busy day. It's hard. It's absolutely hard. But that's the thing. So in addition to drinking is really kind of working on the stuff, less fried food, fatty foods, obviously less, red meats and things like that, more lean meats, fruits and vegetables, is definitely helpful.
Great. Thank you, Dr. Fahora and Dr. Abutaleb. Deborah also wants to know, is there a correlation between patients that had their gallbladder removed and liver disease?
You go ahead, Dr. Abutaleb.
Sure. So I guess it depends. One of the most common reasons that gallbladders get taken out is because of producing gallstones, which cause issues either in the liver, the pancreas, or both. And taking the gallbladder out helps avoid those issues. Towards that end, there are certain other liver diseases that run with this same process of patients that produce gallstones and develop subsequent problems in their liver and in their pancreas. So is there a correlation between patients that had their gallbladder removed and liver disease? By and large, if your gallbladder has gotten taken out, you don't have to worry about some liver disease that might be hiding that's in your body. If there is a connection, it's usually discovered at the time that they figure out the gallbladder is causing problems as well.
Wonderful. Thank you. So for those of us just joining, we are very privileged to have Drs. Vahora and Abutaleb with the GW Liver and Pancreas Institute under the Transplant Institute, talking to us about liver disease 101. An introduction to liver disease and liver transplantation. And we are now taking questions from our audience. We actually have a question from someone asking, can someone be transplanted twice?
I'll take a crack at this and have Dr. Abutaleb kind of weigh in as well. I guess the short answer is yes. We do know that there are some diseases, particularly the autoimmune liver diseases, that when that causes cirrhosis, sometimes those can recur in the liver even after transplantation. And so sometimes when they do recur, and if they do develop advanced liver disease and cirrhosis afterwards, we do have to evaluate them for transplant. Ideally, our job is to make sure that organ lasts them as long as possible. If they do need a transplant, then yes. Sometimes, unfortunately, patients do develop, alcoholic liver disease afterwards in the transplant. They go back to drinking after transplant. Sometimes they may develop fatty liver disease in the organ after transplant as well. And then it becomes a little bit more complicated in terms of the ethical decision of whether to retransplant those patients afterwards, and which is why transplantation, when we do decide and who gets transplanted or not, it's not really up to myself or Dr. Abu Talib. It's not one person. It is a committee that decides, and it is a very, very heavy decision and a big responsibility when it comes to transplantation. Us as transplant physicians, myself, Dr. Abu Talib, and our surgical colleagues, we see ourselves as stewards of these organs. We don't own them. They are not ours. They were gifted to us by families who've suffered the worst loss imaginable, loss of a husband or a wife, a child, a parent. So we take the responsibility in our we have our patient selection committee very seriously to make sure that these organs go to folks who are going to absolutely take care of them the best way possible. So it's a very, very, very heavy responsibility being stewards of these organs. Dr. Abu Talib, anything else you'd like to add to that?
No, I would say you summed it up very nicely. Yes, you can be transplanted twice, but it has to be under the circumstance that the liver transplant is of maximal benefit to you, that it is the best option for you medically and surgically.
Okay, great. Thank you, gentlemen. Another question we have is, how do you help families work with children to prevent liver disease? Is it just a question of, more diet and regimen exercise like you had mentioned, Dr. Bahora?
I think it just depends on what type of liver disease we're talking about here, I think, because there are so many different liver diseases. Some of the liver diseases, such as autoimmune diseases, unfortunately, we don't have a way to prevent them. However, certain, especially with, the obesity epidemic, particularly, in childhood obesity, I think that's where something we could really focus on here is really working with the diet and exercise type situation. And I think that's kind of the big thing that comes to my mind when you're referring to childhood liver disease and whatnot.
Yeah, the two most common causes of liver disease in the United States are alcohol and then non-alcoholic fatty liver disease. If we're talking about children, assuming that under 18 years of age they're not drinking alcohol, the major focus is going to be on healthy eating, quality over quantity, as Dr. Vahora alluded to.
Yeah, that seems to be a very common theme these days amongst any particular disease. Deborah would like to know, have you seen any particular studies that show a particular blood type that is more susceptible perhaps to liver disease?
Dr. Abu Talib, would you like to?
There's no studies that establish that any particular blood type is at a higher risk of developing liver disease.
Yeah, we do know that there are certain things that are genetic markers that right now aren't really commercially available, to my knowledge, for testing for liver disease that are more susceptible to alcoholic and non-alcoholic fatty liver disease, such as the PNPLA3 gene and whatnot. But in terms of like blood, the basic blood types O, A, B, AB, there is no studies that say that correlation is there.
Okay, thank you. You mentioned, normal like fat content. What is considered a normal fat content percentage of a healthy liver?
Go ahead.
Sure. So you're not supposed to have any fat in your liver. You're just supposed to have liver cells, bile duct cells, and blood vessels. So at the beginning, fat can infiltrate into the liver through, again, the two most common causes: drinking alcohol or the non-alcoholic fatty liver disease. You can think of, high carb, high fat diets. And at the very first stage, when fat goes in the liver, plain old fat, it doesn't cause a problem. But then if it stays there and it doesn't get out of the liver, it inflames the liver. And then over time, it scars the liver. So, if you go and have a drink tonight, in the morning, you'll have fat in your liver, but that will go away as long as you don't keep drinking. But if you keep drinking every day, multiple drinks a day, that fat will stay and it will scar down the liver all the way until the liver becomes scarred down to the point where you may have cirrhosis. Similarly, high fat, high carb diets, fat can come in the liver, but if you stop the high fat and the high carbs, it will go away. But if the fat stays, it will inflame the liver and then scar the liver.
Wow, this is very helpful. I was going to go out tonight and have a drink, and I'm really rethinking this decision. I have to be honest with you. I know everything in moderation, but just learning about the real time effects, it really does make you second guess yourself and your lifestyle a bit. All right. So Nita wants to know, how do we get rid of the liver, of the fatty liver, or the fat in the liver, especially if diagnosed with fatty liver?
Yeah, and it kind of alludes to the slide that I had earlier. The mainstay is really diet and exercise. Losing about 7 to 10% of your body weight, we know, can not just get rid of fat, but also if there is some scarring, can get rid of that as well. And having an exercise plan that's kind of with more aerobic exercise can help with that too. Now, sometimes it's difficult for that even to happen for some of the patients, as I alluded to. Sometimes patients have difficulty with that, and understandably so. There are some medications we can also use for this. I didn't kind of dive too deep into that, but there are some medications that we can use, and more medications that are kind of being developed as we speak in the so-called pipeline to deal with fatty liver disease, because it is such a common cause of liver disease in America now. And of course, patients who have battled with weight issues and have obesity and other comorbid issues can be considered for bariatric surgery as well.
Thank you, Dr. Vohora. So I have heard people mention in the past that they were on, medicines that they had to for pain, back issues, neck issues, things of that nature. They were on it for several years, let's say, if they were an athlete, perhaps. And they say it's really wreaked havoc on my liver. Can you kind of just explain that? Is there any truth to that? I was just curious about that.
Amir, do you want to take a crack at this one?
Sure. The liver has, as Dr. Vohora said, is kind of a factory, and one of the things that it does is it metabolizes drugs and turns those drugs into the compounds that we need to give us pain relief. But at high doses and at toxic doses, the liver can become severely injured, and in extreme cases, the liver can fail. And probably the most important pain medication for everyone to be aware of where this can happen is Tylenol or acetaminophen. In very high doses, this can actually cause liver failure. And that's why it's very important to always look at the dosing schedule on your medication bottles and never to go over the maximum. If you go over the maximum 24-hour dose of Tylenol, you risk the liver becoming injured and ultimately failing. And unfortunately, Dr. Vohora and myself all too often see patients in the hospital who did not do it on purpose. They weren't trying to hurt themselves. It was an accident. They were in a lot of pain and they just kept taking more and more Tylenol. Other medications, it's not as predictable and as accurate as it is with Tylenol. Tylenol, we can always tell you with relative accuracy and pretty strong confidence what dose is dangerous and what dose can end up ultimately killing you and causing liver failure. But with other drugs, it's what we call idiosyncratic. It may cause injury, it may not. It completely depends on the person. And generally, you can think of it like an allergy. You know how some people get a rash with the medication, or get hives with the medication. Some people get a liver injury with the medication. Usually, it's not severe to the point where it's causing a liver failure, like we discussed with very high doses of Tylenol. But if that's the case, and you took a pain medication that's causing liver injury, the best thing to do is to stop that medication and talk to your doctor about an alternative.
And the great thing about certain medications, even with Tylenol, if you're taking it and it causes liver injury before liver failure, it doesn't really cause lasting damage to the liver. The liver can repair itself once that insult is removed. But it does take some time for it to happen. The same thing if someone is drinking, or they have fatty liver disease, or they have hepatitis C, and let's say the hepatitis C was treated and cured, but at the time there was hepatitis C the treatment was started, they had stage 2 fibrosis. Over time, and let's say the hepatitis C is cured, they're still stage 2. Over time, over years, that once that insult is removed and no other additional insult is added, let's say they didn't pick up alcohol or gain a whole bunch of weight, that once the hepatitis C is removed, there's no other insult there, the liver can regress and can go back to stage 0.
So Deborah wants to know, once the liver is scarred, regardless of dietary changes and weight loss, the liver, she's asking, cannot or will not repair itself?
As I said, it can definitely repair itself. So once you lose that weight, kind of change, as Dr. Abutaleb said, come off the high fat, high carb diet, lose the weight, kind of develop those healthy lifestyle choices, or perhaps lose the weight with the bariatric surgery and then continue those dietary changes you're supposed to after bariatric surgery, the liver can repair itself and can go back to even normal, as long as it has not gone to stage 4. Stage 4 is irreversible. Everything before that, stage 3, 2, 1, and can go back down to stage 0 over time.
Thank you, Dr. Vohora. Can a liver regenerate similar to a lizard regrowing its tail?
Yes, actually, it can, similar to a lizard, the liver actually has that ability to regenerate. Oftentimes, we've seen that when patients have had various liver damage. Sometimes we see our trauma patients who have had to have certain parts of the liver removed, or more commonly, sometimes we see, if the patient has liver cancer and our surgeons need to do a resection of that cancer out. Over time, we do see the liver kind of regenerate and kind of fill that part again.
How fascinating. Dr. Callender, do you have any questions for our hepatologist?
Yes. I wanted to emphasize that the liver doesn't have a backup like the kidney does.
No.
For the kidney, you have dialysis. What are your thoughts about what we can do in the future for a backup for end-stage liver disease? Any hope?
It's a great question. There are several technologies that have, and various technologies that have been kind of marketed or labeled as kind of quote unquote liver dialysis. The Mars machine comes to mind. And unfortunately, we really haven't seen too much promise with those machines, so to speak. I wish that was the case, but the technology just isn't there just yet to really kind of help in a similar way as the kidney.
Dr. Callender, any more questions?
Yes, what are your thoughts about the possibilities of xenotransplantation for the liver?
Well, since we do have Dr. Abutaleb here, who came to us from the University of Maryland, where they did the first I'll let him work on that question here.
Yeah, I
Gave me
mean,
that tough seat there.
a lot of that science is kind of borrowed from heart transplant, where they've been using pig hearts in humans. And the principal investigator at Maryland spent 30 years of his life trying to get the biology right, and it culminated in the transplant that was done several months ago now. But there's a lot more to go in that field before it becomes prime time. Also, they're looking at a similar but different pathway, which is trying to make organs in the lab through things like 3D printing, bioprinting, etc. In that case, you don't have to figure out the biology of a pig or another animal, but you have to deal with how to get a liver to look and operate exactly like a human liver on a synthetic scaffold. Still a ways to go for that.
Yeah.
Progress is being made, though. All right. I do want to just remind I'm sorry, Dr. Callender, go ahead.
No, I was going to just point out that the growing of livers, as you had mentioned, is something that people talk about in terms of stem cell transplantation and hepatocyte growth. So that the regeneration by stem cells is something that maybe is about 10 years away or so. Any additional thoughts about where we go from here?
Yeah, so I mean, the Takanori Takebe and his lab at the Cleveland Clinic, he also has a lab in Japan. They've looked a lot into this. You can get a liver that is anatomically and functionally adequate, but they can't grow it past a centimeter or two. So the biggest hurdle at this moment is size, in terms of narrative engineering and biologic techniques to get an artery, a vein, and a bile duct together and to have liver cells around it. That's being worked on, but it's still going to take quite a bit of time to create an organ as large as the liver in the lab. And that major hurdle associated with that is supplying it with the proper blood vessel network. Yeah. Which, inside a uterus happens just kind of over several months, in a miraculous way. But in the lab, it's a little bit challenging for us to figure out.
That's so true. And
I think we're very fortunate that this is the month of October is liver month, and so we're really grateful for you to educate us about the many aspects of how liver keeps us alive and what we can do to keep from losing our livers.
Well, thank you so much for the opportunity. Really, really appreciate it, and happy to be here, and look forward to further collaborations with you all.
Yes, well said, Dr. Callender. You took the words right out of my mouth. October is Liver Health Awareness Month, which is why we've had our two topics this month on liver transplantation, as well as just liver 101 and liver disease and all of this wonderful, helpful, comprehensive information that has been shared with us today. Thank you to Dr. Vahora. Thank you to Dr. Abu Talib for joining us today. I do want to remind the audience that, this presentation is for informational purposes and should not by any means replace, their doctor. And we encourage everyone to visit their primary care physician every year and to be checked out and get your, what are we looking for, gentlemen, in the blood work? The I know it's what is it, lipase and amylase is the pancreas, right? What are we looking for when we look at our blood work for liver health?
I think that the two big messages for today is healthy eating, healthy drinking, low fat, low carb diet. And then for healthy drinking, in case anyone missed it from Dr. Vahora's talk, because I know some people joined late, safe levels of drinking for men, no more than 2 drinks a day, no more than 14 in a week. For women, no more than 1 drink a day, no more than 7 in a week. And a drink is a 12-ounce beer, a 4 or 5-ounce glass of wine, or a 1.5-ounce shot of liquor.
Yeah.
I need like that in a poster board.
I think the society needs that on a poster board as well.
You can Google NIH safe drinking, and it should come up. Yeah.
Yes, agreed. Gentlemen, thank you so much for joining
Thank
us
you.
today. Audience, thank you very much for joining us as well with our Kidney Talks webinar with blackdoctor.org. We will be back in 2 weeks for another edition on Friday, November 11th at 2 p.m. And we look forward to seeing you all next time. Take care and stay safe and be well.
Thank you very much.
Thank you.
Well, thanks, Jennifer, letting me get on.
You got it. My pleasure. Take care.
I didn't think it was possible.
We did it.
Yeah, okay. See you Monday.